And then I start the webinar. Welcome, everybody. That was the Queen of Disco, Donna Summer, doing what she does best. I think when we had our disco era, before most of you buzzards and iguanas were born, we had probably the top 10 disco songs of all time. Probably 5 or 6 of them were by Donna Summer. I saw her in concert once at the Meriwether Post Pavilion in Columbia, Maryland. She just blew everybody away. We took our secretary there from the pathology department, and there was this strange smoky smell all over the place because it was an outside concert. So the next day, she told everybody that she was at the Marijuana Post Pavilion. It was really called the Meriwether Post Pavilion. Okay, we're online, we're rocking. Today is Tuesday, it's January 22nd. I'm still Dr. Minarcik, and this is our 34th 2-hour free global online medical school pathology course session. It's also our 15th encounter with our hybrid with the iguanas as well. It's 8 o'clock a.m. here in Caguas, Puerto Rico, and I'm getting tired of talking about what time it is in Chicago. So this is a good time to do the test before we get into what we're going to be doing today. And we're going to do our audio-video test. The audio test has two parts, a part A and a part B. The audio test, first question is, can you hear me? Okay. The part B of the question was, did you hear the music well? Yeah, we think you did. Good. Now, part B is, what do you see on your screen? Just so we know you're getting dazzling resolution. It's probably much better than what the iguanas are seeing because we don't have a quite perfectly sharp monitor in the middle. We got a couple of better ones on the sides. Okay, so you see the fluorescent flowers. And I think we're ready to rock and roll. Okay, today will be devoted entirely to pathology lab. This will be our endocrine histopathology lab session. We've had 3 sessions already talking about various diseases of the pituitary, parathyroid, thyroid, adrenal, pancreas. And you know, we've showed very graphically some of the salient features, grossly and microscopically, but now we have the real slides. And for the buzzards, you all know what that means. It means it's going to be very, very, very interactive. In fact, I'm not even sure if I'm going to let anybody run the screen today. I might have to do it myself because most pathologists prefer talking to people on the other side of their microscope. So when I was in practice for 8 million years and a doctor came into my office, you know, he would sit on the other side of my desk and I would have the slides under the microscope and he'd be sitting on the other side and I would say, yeah, this is this and this is that. And of course the surgeons would say, oh yeah, I knew that. That's a Reed-Sternberg cell. Of course they didn't know it, but you know, the surgeon never admits he doesn't know something. That's one rule. You got to live with it, deal with it, okay? Also, I would like to remind you again that today we're going to do something a little different. I didn't do much work on this. I always like the labs because I don't have to prepare much. It's stuff I've seen my whole life. All I got to do is show you the important parts. But today, we're going to be thinking backwards. It is crucial for our exam, for any USMLE exam, that you think backwards. Now, when you get to the major university centers, they have something called a CPC. Sometimes they call it a death conference, or maybe the name has changed. But basically, the pathologist shows autopsy findings, okay? Either before or after the clinical presentation. Sometimes after, but sometimes before. And then you go from these findings, you know, parathyroid hyperplasia. And then you go think backwards as, what did this patient come into the doctor's office complaining of, or the emergency room? So in every case, we talk about a slide. We have 25 slides today. In every case we show a disease entity, I want you to think, what did this patient come into the presentation scenario as? If you get into the habit of thinking that way, trust me, you are going to do very well, not only on this upcoming exam, which we're going to review on Thursday, but also for the USMLE in general. Now, I want to make one more comment about lab in general, and I also want to make a comment specifically about Rock Lab, which I've already said a couple of times. There are people high up in the so-called medical education hierarchy that don't believe it's too important anymore to show pathology slides. Now, in my days, everybody, for the next generation or two, they all saw pathology slides. We had microscopes. We had glass slides. We had sessions where we'd try to find things and fill out little booklets with our friends. That seems to be a little bit waning, mostly because of financial reasons, because schools don't want to buy microscopes anymore. And even now that we have virtual microscopes with computers, they're even too cheap to hire somebody that can show all of these to students that knows what he's talking about. Believe me, I'm not being unnecessarily critical. I know a lot of schools that they say, Oh, we don't want to hire a pathologist. Let's get a graduate student in immunology to show people what tumors look like. It just doesn't work that way. You're going to get real good old-fashioned pathology. How could you imagine learning radiology if you didn't look at x-rays? But even more important is you have to remember that most people, not just pathologists, most people who study disease visualize that disease by actually looking at it. Okay, how could you talk about Toyotas if you've never seen a Toyota, you know? You got to look at various normal aspects. You have to have a kind of a good basic imprinting of the normal. We're going to be looking at normals today too. And then how the histology deviates from the normal. Okay, I'm done with that part. But if some school ever tells me I am not allowed to show slides because the students would rather sit in a room in a small group session, hold hands and talk about what they read in front of an immunology PhD candidate, I'll basically tell them to go to hell. Okay, now let's talk about the lab that you're going to be going to. Is called Rock Lab. All of the cases that we're seeing today, they're on my website. They're part of the 500 slides, which you could go to yourself and look at. And you don't need me. In fact, I've made sure that when you look at these 500 different disease entities, that you also have the benefit of a maybe 3, 4, 5, 6-minute movie that describes it. And these are movies I've made years ago. And when I made the movies, I was actually organized. And I was thinking, well, what should I make sure I include this and this and this. Now we're going to just be talking more spontaneously. So I would not recommend you to listen to all the movies. But what I will recommend is that if you really want to learn pathology, maybe a little bit more than you have time for, that you look at all of those slides. We'll be looking at them like little pieces at a time. We'll look at about 25 today. I recommend you look at all of them from the point of view of this is what the actual disease looked like, you know. He's been talking about a acetophilic adenoma of the pituitary. Damn, that's what it is. That's why they call it. I could see the little prolactin granules coming out of the cells. That's the best way to understand disease. And for those of you, every year there's a few people, it might be 10, it might be 8, that do all of the Rock Lab cases either by themselves or with their friends. And when they do it, they submit them, the whole batch, and then I say, okay, well, you've submitted all 500 cases, got the answers. Now I want you to talk to me on Skype for 5 minutes. I don't want to call it an oral exam because that has a devastatingly high anxiety effect. But if they do that, I then just say, okay, well, you know, how you doing? Tell me a little bit about these granulomas that you showed me over here. You've already said that there's 4 different common causes for them on your submission. Do you remember what they were? If they remember what they were, I'm very happy, and I give those people extremely good references in their careers. Or actually, I don't really write the references. I basically just have them say, have your mother write it. You know, have your boyfriend or girlfriend write it. Let me look at it, and if I agree, I won't change it very much. Because I write like probably 500 references a year. I just don't have the time to do them all myself. Okay, we're done with all of the things I didn't want to make sure I forgot. So let's go to the lab. Here's the microscope. I am not going to have Mario touch or Jennifer touch the microscope today because a microscope is a very, very personal thing with pathologists. It's like a cowboy and his horse. You know, there's something that they just feel like totally comfortable with. But what I did now was I took, let's see. I think you'll agree there's about 25 cases here. That's all of them right there. And like Rock Lab, they're arranged alphabetically, okay? So even though we might have talked about the pituitary before we talked about the adrenal, I don't think we have to go to lab the same way. So the first bunch of slides are named ADR, and then the next few are named PIT, and then the next few are named PTH. So I think you know the order that we're going to do it. And also, if you look at the name of the file, you know, you could probably figure out what it is even before you look at the slide. That's okay. I don't care. But the important thing is when we look at these slides, I'm going to be asking you all questions about them. Some of the things I'll just be showing you, like the normal aspects of an adrenal, let's say. Some of the things I'll ask you, I'll say, do you think this is necrosis if you can't see the nucleus? And I want you to answer. Now, actually, the iguanas are in a very good position because we have a lot of people out with the buzzards that are pathology residents. And they are very sharp on this stuff. So whenever you see somebody give a response quickly right on the chat window there, you know it's probably going to be correct. So you can look to see what the pathologist from Pakistan is saying. And I guarantee you, if you just want to repeat what he says, that's fine. And also, I don't want to embarrass anybody. So, but I will tell you that if some of the responses that you'll be seeing streaming down here, if they're generally not at all the kind of things that are going through your mind, you might feel a little anxiety. You might think, oh, I still need to brush up a little bit on histology. But most likely, when I ask you a question, I don't expect to single anybody out. They'll probably already begin. And there's even some wise asses up there. I think in Egypt we have like a lot of really smart people. And probably they'll even give the answer before I give the question. I don't know. There's a lot of smart people in Egypt. I don't know why. Maybe I should go there to increase my IQ points. So I think a good place to start, and I hope you can all see the microscope well, whether you're looking at the middle screen, which is a little bit off-center for color, or the sharper but smaller side screens, or maybe you got your laptops and you're on the webinar right now. Let's look at something called ADRNL. I wonder what that is. This is a normal adrenal gland. I think you know that already. I want you to take a look at it. I want you to see that the center part of these little ribbons, or whatever you want to call it, is very, very, very vascular. Like it needs blood quick. You know, like maybe that's the adrenal medulla. And there's a lot of big veins in there. If you remember, they're called central veins. And then if you look closely, you'll see ganglion cells, sort of. But everything from about here to here is the adrenal cortex. So the reason why we're going to look at them, and the reason why they might look a little bit foamy, here, let's zoom in on the northwest here. The reason why they might look a little bit foamy when you look at the cells is they're loaded with cholesterol because they have to make steroid hormones. Now take a look at this outer layer here first. Oh no, let's not take a look at the outer layer. Let's just say that the majority of this adrenal cortex, which is pretty much goes from here to about here, looks like they're composed of strands or fascicles of cells. Don't you agree? So usually the majority of the thickness of the adrenal cortex is the zona fasciculata, and you already know that's sugar. Now, if you look at the outer area, however, and we're going to do that, let's look at just that one area. You might have to stretch your imagination a little bit, but doesn't that look like a little glomerulus, and maybe that? They're not really quite as straight as the areas underneath. This is the glomerulosa. This is your salt. This is your sugar. You see how they're more linearly arranged? And also notice how foamy they are. Could these be mistaken for foamy macrophages? Of course they can, because they're loaded with cholesterol. And then as you go down, right before you get to the medulla, you might have to use a little imagination here too. This looks like you're into wide open vascular spaces, but I'm suggesting that this less linear and more of a cross match, like you might see on a reticulated python, is your zona reticularis, you know, the sex hormones. So there is your GFR, glomerulosa, fasciculata, reticularis. And then whenever you should normally see in the middle of the adrenal, these, by the way, and this is an excellent slice, by the way, are these big vascular spaces, and you know that's the adrenal medulla. And they don't look at all epithelial, but they look very, very, very vascular. There's a lot of smooth muscle around these big central veins. And I'm going to zoom in. Oh, I don't know. I'm going to try to convince you that some of these cells look like ganglion cells. But I might have a hard time because they really don't, okay? But this is the adrenal medulla, not looking quite as epithelial as the adrenal cortex. Okay, should I start asking questions, or do you want to see another normal? Let's look at another normal. Here's one called NL2. So I wouldn't pick anything unless it was pretty good. Now you see the artifact on this, these straight lines? You know that's not part of anatomy. That's just some slicing artifact or maybe digital artifact or something. But look once again. Do you see how the medulla, I'm going to drive along the cortical medullary road here. Cortical medullary, cortical medullary, cortical medullary. So here, all this is cortex, all this is cortex. This little strip in the middle with all the blood vessels is medulla. I'm going to also convince you that we got a GFR here as well. But before we do that, let me ask the question. If this was a totally representative section of the adrenal gland, what tissue would be more common here? Cortex or medulla? Yeah, cortex. Everybody's saying cortex. A couple of people said medulla, but remember, if you took this as your thickness, probably 2/3 of the thickness here is cortex, and only this little vascular center is the medulla. Now, you want to go to GFR again quickly? Because if you just remember GFR, salt, sugar, sex. That's all you have to remember about the adrenal. Look at, here's your little glomeruloid bodies, okay? Now they're getting more linear here, like fascicles. The stuff here that's very, very vascular is the medulla, but it becomes less linear before you get to the medulla and more cross-hatched or reticulated. And this is a really, really good. Now, if you took this slide and you put it against your white lab coat, what would be the thickness from here to here? What's the average thickness of the adrenal medulla? I'm looking for answers. Yeah, I'm sorry, somebody already said it. 1 millimeter. Somebody said 1/2 millimeter. Somebody said 1. Most people are saying 1 millimeter. Now, can I ask another question? Just out of curiosity, give me a quick estimate as if from here to here was 1 millimeter. How many cells thick is that? Is it 2 cells thick, 20 cells thick, or 200 cells thick? That's my question. Yeah, somebody said 100. Yeah, we're in that range. And also, what would you call this fibrous connective tissue just outside of the adrenal cortical zona glomerulosa? That's just the capsule. Good. Somebody's out there that's really sharp. And if somebody wants to just think or say whatever D-I-N-E is saying, I don't know the rest of their name, then you know that you're going to probably be saying the right thing. I suspect that D-I-N-E is already a pathology resident. Maybe I'll consider hiring that person to help answer the student's question. Okay, we're done with normal adrenals. Okay, you got a good general picture in your mind for what a normal adrenal looks like. Good. Take that quick picture. Now I'm going to show you something else. Well, you can see the capsule again, can't you? You can see some fat around the capsule, can't you? You could see some big vascular spaces here, more towards the middle, that have a lot of smooth muscle around them, the central vein of the adrenal cortex. But take a look at the full thickness of this adrenal itself. And let me ask you a question. Number one, is it a lot thinner than normal? Yes or no? Yeah. Rather than 200 cells thick, here's the medulla, rather than 200 cells thick from the medulla to the capsule, there might be only 20 cells thick. Okay? Now, let me ask you another crucially important question. 2 more questions. Is this adrenal cortex here nicely arranged into G, F, and R? Yes or no? Okay, last question. What are half of these cells within the circle that I'm making? Are they inflammatory cells? Are they lymphocytes? Yeah, they are. By the way, iguanas, raise your hand if you could believe or agree or understand that most of those cells are lymphocytes. Well, I'm getting a couple. I'm getting half at least. So why would lymphocytes attack the adrenal cortex diffusely? Do you think that there's an organism in there like staph or, E. coli? Or let's say I told you that you cultured those adrenals and there's no organism, there's no virus, there's no bacteria, there's no fungus. Why would lymphocytes attack for no reason your own normal adrenal cortex? What kind of disease? Yeah, somebody's already saying autoimmune. What is another name for autoimmune adrenal cortical itis? Addison's disease. It's the most common form of an acquired chronic adrenal cortical failure. So here, I want you to go back again. I want you to be really smart because I'm not going to give you the answer. Okay, I'm only a pathologist. I don't know a damn thing about patients. But I want you to take this adrenal cortex now, which is thinned or atrophic, and is attacked diffusely by lymphocytes. And I want to ask you, how did they diagnose this? So you know what you're going to have to do when you get home, if you haven't done it already? You're going to have to go to Wiki, you're going to have to go to your book, and you're going to have to look up the presentation symptoms of Addison's disease. And they're going to say things like weakness, lethargy, maybe a diffuse effect of low concentration of all adrenal cortical hormones. So will this person have decreased aldosterone? Sure. Will this person have decreased cortisol and all its effect? Sure. Will this person also have decreased estrogen and androgen type hormones from the zona reticularis? Yeah. So that's what I want you to do now with every slide we look at. In fact, if you went to Google, if you got a book, if you got first aid, if you got Goldjohn, if you got Robbins, I want you to right now, while you're listening to me, you won't have to interrupt me. I want you to go back, probably Wiki is what I usually do, and look, say something like clinical presentation Addison's disease. And that is what's going to help you to really kick ass on the exam. Okay. By the way, I'm going to ask the buzzards right now, what is the most likely way that this adrenal gland walks into the emergency room or the doctor's office, and what does the patient say? He goes, oh, I've been feeling weak and tired and lethargic. Now, that's pretty nonspecific, but that could very easily be the thing. Will x-rays show much of anything? Probably not. If there was a way of measuring autoantibodies against the adrenal cortex, would those be positive? Yeah. Would there be decreased amounts of hormones in all of the layers that produce adrenal cortical hormones? Yeah. Somebody said hypotonic urine. You could believe that's true. Somebody said hyperpigmentation as well. Yeah. And let's make this very, very simple now. Who is the most famous person in history to have Addison's disease? Yep, JFK. Everybody knows that. And last question is, well, how do you treat this patient? Duh. How about steroids? Okay, just as a curiosity thing here, I want to tell you something else. We've said this in class, but I want to say it again because this is kind of like a review. Let's say that this was not an autoimmune infection of the adrenal cortex. Let's say it was an infectious etiology. What kinds of organisms love to infect the adrenal cortex? Fungi, the systemic fungi like histoplasmosis, blastomycosis. And here, last but not least, if these were metastatic cells to the adrenal gland rather than inflammatory cells, which you see here, and it was the only organ that had metastases, what is almost certainly the primary source going to be? The lung, yeah. The adrenal glands are magnets for bronchogenic carcinoma metastases. When a pathologist does an autopsy on a person that's had lung cancer and he doesn't find any evidence for metastases, in the liver or in the bone, he is going to slice those adrenal glands very, very thinly because the adrenals, and don't ask me the reason, I'm sure a lot of people have theories, but just remember, the adrenal glands are magnets for lung cancer metastases. Often the very first place they metastasize to, possibly even before they go to the lymph nodes. Okay, we're done with that one. Let's go to the next adrenal case. This will be even easier. I think you'll already see what it is, so you're biased. I should mislabel these someday. But here, this is what I want to point out. You don't have to be a pathologist. You don't have to be a histologist to figure out what this is. All you got to do is to be a 3-year-old kid. Now, if I had a 3-year-old kid here, and I wish I had some in the audience. I know you're all young, but not quite that young. Let's say that I've already convinced you that this is the adrenal cortex and this is the adrenal medulla. Okay, I know you already agree to that, and there's the adrenal capsule, and there's some fat outside the capsule. Now, I think you already know that even though this is your normal 1 millimeter ribbon here, and this is your normal yellow 1 millimeter ribbon here, and this is your medulla, you have a big, big, big nodule that is 10 times as thick. Now here's the only question I have to ask you. And don't think like a medical student or a stupid pathologist. Think like a 3-year-old. Does this big nodule here look microscopically like the cortex or the medulla? That's the only question. So and look, everybody's saying cortex, and I know you're probably thinking cortex too. So the next question is, does it look like it a lot? Yes or no? Yeah, it does. They look almost identical. So if I told you this was a tumor of the adrenal cortex, you'd totally believe me. And because it looks like it a lot, in other words, this is benign adrenal cortical cells, this is also looking like benign adrenal cortical cells, what would your diagnosis be? Adrenal cortical adenoma. Okay, I hope I'm being logical. Now, could this tumor be producing an excessive amount of adrenal cortical hormones? Could it be producing a Conn's syndrome if it is producing more mineralocorticoids than it should normally be, independent of regulation? Because remember, tumors are independent of physiologic regulation. Could it result in Cushing's syndrome? And of course, I know you're all saying yes. But let me ask you another question. Could it also result in no endocrine-like syndrome? Yeah. So just because it looks like adrenal cortex, that doesn't mean it has to be producing an overabundance of hormone. And I want to tell you something right now that you're not going to find in the pathology books, But when you do 1,000,000 autopsies, I know I haven't done 1,000,000, maybe only 500,000. If you just do a careful autopsy, you'll see these little thickenings, nodular areas of the adrenals often. I don't mean like 90, I mean like 10 or 20% of the time if you cut carefully. And most likely that patient has never had any type of excess of adrenal cortical hormone syndrome. Now what we're going to do is we're going to go to the southwest here, and we're going to zoom in on the actual cells in very high power. And I think, and there you go. Do those look like normal, foamy epithelial cells? Yeah. And I'm going to go to the adrenal cortex next, and I'm going to show you something that'll look exactly like this. And by the way, when you see a blood vessel here, a blood vessel here, a blood vessel here, 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 doesn't this kind of confirm what we already know about endocrine tissue in general, that it's very, very, very vascular? And I'm going to show you something else. I'm going to now go to the adrenal cortex, and I bet you when I zoom in on this little area here, it's going to look exactly like what we just saw in the tumor. So that tells you two things. The tumor came from the adrenal cortex, and because it looks exactly like the adrenal cortex, it's probably benign. That's how you make the diagnosis. Okay. By the way, buzzards, you're doing pretty good. I think the iguanas are in sync because I'm looking at their faces in this dim lit room. But I think they're pretty smart too, but unfortunately they don't have to type in the answers. Actually, you don't have to either, but there's always some smart people that volunteer to help their peers. Somebody said angiogenesis. Yeah, well, isn't that a feature of all tumors? You know, angiogenesis. If a tumor, benign or malignant, didn't have some way of making blood vessels, the tumor could never be more than 1 or 2 millimeters big, could it? Wouldn't that be great if we could figure out how to stop tumors from making angiogenesis factors? It means that the worst cancer in the world would only be like 1 millimeter, probably never hurt the person. Okay, let's go to the next one. Oh, this will be easy. This will be a quick, easy one. Why do you think I named this adrenal Amy? Because she looks like my friend Amy? Okay, so here's the fat, here's the capsule. These big wide open slits are medulla. And so this pink stuff is the cortex. And I'm going to tell you, here's the capsule again. Look, you can still make out somewhat of a glomeruloid pattern here. But folks, so, see, a couple people already gave you the answer. So I'm really mad at you. No, not really. So let's zoom in. You can see the majority of this adrenal cortex. Yeah, they have epithelial-looking cells, sort of. But what do you think is all of that hyaline, eosinophilic, amorphous material, which, by the way, is the definition of hyaline? Could hyaline be fibrous tissue? Could it be fibrin? Could it be amyloid? So what stain would you probably order? If you really thought this was fibrous tissue, you get a trichrome stain, right? And it would be green. If you thought this was amyloid, you get a Congo red stain, right? And it would be red. If you then took that red Congo red stain and did the little polarizing trick on your microscope and it's green, you've proved it's amyloid. Last question to everybody. And I love this kind of format because you're not only learning from me, but you're also learning from the buzzards. So I have a feeling when I ask this next question, somebody's going to get it right really fast. Okay, so you have an adrenal gland that's loaded with amyloid. Do you think this is the only organ in this person's body that had amyloid? And they're all saying no. And that's so if one organ in the body is loaded with amyloid, it means probably it's everywhere. Now, there are certain types of amyloid that are fairly organ-specific, you know, like heart, maybe liver, maybe spleen, that are primarily limited to the organ. And those wind up usually being the familial types of amyloid in general. But if, generally speaking, you see amyloid totally wiping out an organ, chances are it's in a million other organs too. Okay. So inadequate amounts of adrenal cortical hormones is probably the least of this patient's problem. He might have a cardiomyopathy also. He might have liver failure. Okay. We're done with this quickie. And, oh, this will be an easy one. And we're going to have to use a lot of intellectual honesty in this case. And it will be easy. First of all, nobody here, if I told somebody this was adrenal, they'd probably say, prove it. It doesn't look like adrenal to me. But the only proof I have, Your Honor, that I submit before you, is that this little capsule that you see here, and I'm going to call this adrenal even though it doesn't look like it. This little capsule is sitting on top of this. And what is this on the left, the East Coast? What is that? That's the world's most normal kidney, isn't it? So this definitely deserves the name adrenal because it's on top of the kidney. Look, there's a glomerulus. Here are tubules. Then here's the capsule of the kidney. Now here's the capsule of the adrenal. So this is one of the adrenals that just happens to be sitting on top of the kidney. And I'm going to slide it down there. And you can see it's still very, very, very vascular. But you don't really see any differentiation between cortex and medulla. And you don't see any differentiation between glomeruli and vesicles and reticular. But what you do see are cells that are very, very, very malignant looking. You see that cell there? That's a mitosis that wants to go in 7 directions. I can't think of a single benign cell that wants to split off in 7 different directions unless it's malignant. So multipolar mitoses. Another thing I want to point out, you know, it's just as vascular as normal stuff. The thing you don't see here is necrosis, but I bet you if I move down to another field, you'll see necrosis. Yeah, what do you call this granular junky stuff, where the nuclei are just crumbly and split up and fragmented? That's necrosis. Now remember I told you several times in the last few days that endocrine tumors frequently can have a lot of atypia, but still be benign. It depends on whether they've metastasized or invaded the capsule. But what about a tumor like this that has not only massive atypia, but necrosis? Here, let's make this very simple. Any tumor that has both massive atypia and a lot of necrosis is a malignant tumor. I'm sure if my pathology buddies were on this side of the auditorium, they'd probably think of 5 or 6 exceptions to that, but not right away. So this is an adrenal cortical carcinoma. Next question is, if these adrenal cortical carcinoma cells do not look at all like normal adrenal cortex, do you think they pump out the hormones like normal adrenal cortex? No. So how many years do you have to practice pathology before you see a functioning adrenal cortical carcinoma producing a hyper adrenal cortex endocrine system syndrome, like Conn syndrome or Cushing syndrome? Somebody said 30 years. Well, I did 40, and I've only seen one, so I would accept 30 years. Okay, we're done with this one. I hope I'm pointing these things out clearly. Oh, here's a great one. You're going to get this one right away. Excuse me. Here's fat around the adrenal. Remember we saw the adrenal, there's a lot of fat around it. The weight of it is only about 4 grams. It looks like it's 8, but it's all fat. It's almost impossible to peel away all the fat. And by the way, what is this over here that I have my pointer in? And what is this? Vein is correct. Okay, now what is this over here? And what is this? This is the bonus question. What is this? Yeah, that's a nerve. Somebody figured it out. We'll zip it a little bit better. So within that fat, you see both nerve, classical nerve, a nice thin-walled vein, and a thicker walled artery over there. Okay. But that's not why we're here, to study arteries, veins, and nerves. We're here to show you adrenal diseases. In fact, I'm going to make this question really, really tricky. Here's the adrenal cortex. You see this big, long vein in here? That's the central vein. There's the medulla. So let's take the entire thickness of the adrenal gland from the capsule to the middle of the adrenal medulla. Okay, there's fat, there's capsule, and there's a big vein in the medulla. Is this adrenal cortex thicker or thinner than normal? It's massively thinner, isn't it? Rather than 200 cells, it might be 20 cells. That's really thin. So go back. This is the trick question. Go back and take a look at this adrenal gland and say, oh my God, there's almost no cortex there. But it's not inflamed. It's not lymphocytes wiping it out. It's a thin cortex. There's probably not much hormone being made. So when that adrenal gland walks into your office, what is it going to say? It'll say, oh, doctor, my adrenal cortical steroids are low. This is the reason why it's a trick question is what if I told you that every adrenal gland you see that has almost no cortex, what if I told you that patient is going to have hyper adrenal cortical hormone levels? Do you believe me or not? Most of the cases of adrenal glands that have really, really thin cortices are people that are on large amounts of long-term steroids. Does it make sense? Clinically, they're hyper, but anatomically, they're hypo. Why? Because the external steroids are feeding into the pituitary to shut off TSH. That's probably the single most likely adrenal gland you're going to have in your patients. Because when your patients get extremely ill with life-threatening diseases, you're not going to be worried about a buffalo hump or a moon facies or hypertension or diabetes. You want to keep them alive for a few more days. So if you are on high-level steroids for more than a few days, their cortices are going to atrophy. Now, what is the problem with the word atrophy? They call this the atrophic adrenal cortex, but it's not really atrophic. It's hypoplastic, isn't it? Decreased number of cells. But you see, they still use the word atrophy only because it's a convention, but it's not correct pathologically. Okay, let's go to the next case. Oh, we're still on adrenals. Okay, I'm going to show you another case here. This is not going to be terrible. Oops, I already showed you that one. Let's see if we got cortical atrophy, neuroblastoma. Okay, I'm going to show you something interesting now. And we're going to use the same logic that we used with the adrenal cortical adenoma. See all of this from here to here. See where my pointer is? From here to here. That's adrenal cortex. It's only 1 millimeter. Okay? Now, the rest of this substance here is adrenal medulla, but it looks like it's massively enlarged adrenal medulla. Okay? So let's say that grossly this was a tumor, and you look at the tumor, and the tumor isn't yellow like the adrenal cortex is, but it's the same color, this purplish hemorrhagic stuff, as the adrenal medulla. And it looks like adrenal medulla, both grossly and microscopically. Okay, I've said enough. I'm sure half of the buzzards already gave in the answer. Yeah, they did, actually. This is, as we see streaming down now, a pheochromocytoma. And remember the 10% rule for pheochromocytomas? 10% bilateral, 10% kids, 10% malignant, you know. The one feature that I have also mentioned about pheochromocytomas, I gave you the little poem, pheo is pleo, is that even though it's a benign tumor and it looks a lot like normal adrenal medulla, if you zoom it in, look at, you're going to see a lot of cells here that are big and dark and pleomorphic. This is not the worst field, but I bet you if I drive to about 5 more cities, we're going to see some giant, really bizarre looking cells, like maybe there, but I bet you I could find worse ones. What about that one? That looks pretty nasty. It's big, it's dark. You would normally, if you took that out of context, if you showed that to a cytologist, they would probably call it a malignant cell because they don't understand that you can get these severe atypias in not only pheos, but many or most endocrine tumors in general. So the question is, how do you know if this is benign or malignant? Because I've already said that 10% of all pheos are malignant. Well, let's say that you found this same type of tissue in a lung. Would you have a hard time calling it malignant then if it's metastasized? Let's say that you saw that same tumor totally invade the adrenal capsule. That would also help you, wouldn't it? Because you really can't go just by how the cells look like. You know, I don't know if we threw in any pheo questions, but if you just remember the 10% rule and, oh, so that adrenal medulla walks into your office. And what did they say? Hypertension, big thing. But take a look. Please look it up yourself. There's probably a few other buzzwords I want you to remember for the presentation of a pheo. Hypertension is always at the top of the list, and it's always at the top of the list. When you go through your big discussion on hypertension, and they're going to say, well, you know, most hypertension is, you know, what we call idiopathic, or, you know, we don't know what causes it, but something with the kidney. They're always going to say, there is one rare form of hypertension that is 100% surgically correctable, and that's take out the pheo. So your epinephrine, norepinephrine isn't being pumped out in increased amount. And why does that also prove that most of them are benign? Here, let me ask you this. Let's say you have 2 patients with pheochromocytomas. One's hypertensive and the other one isn't. Which one is more likely to be malignant pheochromocytoma? The one that isn't, because it's not differentiated enough to do what it normally does, and that's to make epinephrine, norepinephrine. Okay. Let's go to another tumor here. We talked about it, and this will be the last one that we do. Let's see. Yeah, let's do, there's one more I want to show you. Okay, we got the slide under the microscope. And the first thing you're going to say is, gee, I don't know what that pink or fibrotic looking stuff is in the middle, but I do know that whatever this is, it is very, very, very vascular. Look at, you have almost every other cell is a blood vessel. Okay, and you're looking at it. Now, I don't know, there's probably a couple of wise-ass buzzards up there that already spit out the diagnosis, but when you have a tumor of the adrenal, it doesn't look like cortex, and it doesn't look like a pheo. What's the second most common tumor, usually malignant, of the adrenal? Is a neuroblastoma. It's also the second most common solid tumor of young children, 2-year-olds. So if you suspect this as a neuroblastoma, what's the buzzword that's going to be on the exam? Begins with a R. You got to find one or two. Rosette. Somebody have the mouse? Mario, I want to point out a couple of rosettes, if you'd like to. If not, give it to Carolina. I could already see a couple that are pretty good candidates. Here, my hands are not on the mouse. I want you to point out. You want me to go higher power? Hold on, I'll go higher power. What? That's too high. Let me drop down a couple of notches. Okay. I could see two. What are the two best candidates for rosettes in this field? That's the best one, in my opinion. That's the third best one. Yeah, that's the second best one. Do you see how the nuclei are just kind of surrounding a cytoplasm? Rosettes, maybe some wise guy will put in the word Homer Wright rosettes, just so they sound cool. Okay, I think we're done with adrenal. It is 8:54. We want to do all these cases. So, there's 4 cases on pituitary. Let's do pituitary. And 2 of them are normal, by the way. I think I might have actually took a picture of this. Carolina, do you still have the mouse? I want you to drive around the adenohypothesis only. Yeah, you're there. Here, let's make this simple. Show me the general division between the adenohypophysis, which look like glands, and the neurohypophysis that looks like brain. There you go. What are those little sort of thyroid follicle looking, a few scattered things in between? Remember there's a pars intermedia? And nobody is able to figure out yet what that does. So I'm not going to tell you what it does. And next question to anybody, as long as Carolina is driving, what percentage of this pituitary gland is neurohypophysis? Give me a number, and then we'll see if Carolina agrees with you. I got 15%, I got 10%, I got 20%. That's the range. Nobody's gone more than about 30. I personally would say something like 21.3426, but that's the right range. Now, the second question is, point out the pituitary stalk, Carolina. This is a normal pituitary. Now, what are the number of axons in the pituitary stalk? Like 326,000? I don't know. There's a certain fixed number. The neuroanatomist told me that. Now, are all of those axons, are they going to the adenohypophysis or are they going to the neurohypophysis? And everybody's getting that one right. And, okay, now what I'm going to do is ask you, do you see that some of the cells now in the adenohypophysis look very red, even from this power? What do you think those are called? If there was a tumor of the red cells, name 3 syndromes it might produce with the patients that walk into your office. Galactorrhea, acromegaly, or giantism. Okay? Now, do you see how some of those cells are not really quite red, but especially towards the top, they might look a little bit bluer? So what I'm going to try to do, you can still use the mouse if you want, but I'm going to override you for a second here. And I'm going to zoom in on an area like this because I think I'm going to see both. Oh, look at that. Isn't that beautiful? Okay, Carolina, I want you to point to 20 basophils precisely. Okay, well, there's about 5 or 6 there. Okay, stop. You got it good. I want you to now point to 20 acetophils. They're more towards the bottom, aren't they? But remember, the really, really red things are blood vessels, aren't they? Now, why are infarcts of the anterior pituitary not really quite too common? Because it has a secondary portal circulation, remember? Just like the lung, just like the liver. It's a secondary set of veins which makes it more and more and more vascular. And I'm going to ask you a totally unfair question now, because I haven't really found it myself yet. But what I'm going to do is I'm going to move to another area. Oh, I don't know. How about if... Oh, yeah, I think I see one. What I'm going to do now is ask you, whoops, to find me a chromophobe or two. I could see 3 of them already. Yeah, that was the one I thought was a chromophobe. There's another one in another area. That's a chromophobe. Here, I'll point out all the things I think would be, they stand out like halos. Like that's probably a chromophobe, that's probably a chromophobe, that's probably a chromophobe. The one that you pointed to is definitely a chromophobe. And maybe this is one, I don't know. So, tumors of the acetophils are producing syndromes like galactorrhea, pituitary giantism, acromegaly. What about tumors of the basophils? What kind of syndromes might they produce? Cushing's, always at the top of the list. What's next? Hyperthyroid. Remember, they also can they produce sexual syndromes. Another thing I didn't tell you is when I said that all of those axons are basically, go into the posterior pituitary. For some reason, if there's a pituitary stalk injury, like with the head injury, even though it's basically just the posterior pituitary that suffers the brunt of it, with a decrease of hormones there, for some reason, it also very often stimulates the acetophils. So head injury can also result in galactorrhea in a woman. And by the way, did all of you get that review sheet from Jennifer? You better memorize it. Okay. I'm not going to do the other normal pituitary because this one was so much better, but I generally like to, once you have a really, really clear feeling for the normal, the abnormal becomes real easy. I'm going to show you this one. Let's say if I told you this was a pituitary, you'd have to believe me because it doesn't look like nerve tissue for posterior pituitary, and you don't see a lot of mixture of acetophils and basophils like you would in the anterior pituitary. But let's go into a representative area like this. Now, this is a tough question because normally when I ask you to find the acetophils, you just look for the cells that are redder than the blue ones. When I ask you to find the basophils, you just look for the cells that are bluer than the red ones. In all honesty, if I asked you, are these acetophils or basophils, probably I'd get a split opinion here. What if I told you this woman had galactorrhea? Okay, now here's the other thing. It's 100%. Right? Every cell in there, 100% are acetophils. Okay, and if you did a stain that stained for prolactin, which we could do, they would all be prolactin positive on your pathology stain. 100%. Does that make it more likely to be a true tumor, an adenoma, rather than a hyperplasia, which would be mixed, maybe red and blue? Yeah. That's another key concept. I'm going to show you one more picture, and then we're going to take our break. And that picture is right here. This is, you know what? Carolina, drive your car around the neurohypophysis now. Very good. What are those little follicles look like between the neurohypophysis? Remember the pars intermedia? By the way, I'm just curious. When you took histology last year and they showed you the pars intermedia, did they tell you that it did anything? No, I'm serious. I just don't remember it doing anything. I guess you could probably wiki it and find some research, but I don't think it does anything. Just looks like a few scattered thyroid follicles between the two. Now, does anybody want to take a general guess at this power? What's generally wrong with the entire gland? If you don't want to take the guess, I'm going to zoom in a little bit. Remember, we may not be talking about, I'm going to zoom into an area like this that has both neuro as well as adeno and even, okay, how many distinct, crisp nuclei can you see? Or does it look like maybe the nuclei might have dissolved in most of those cells? Remember, it's called karyolysis. You see karyolysis in coagulative necrosis. And remember, I told you that infarcts of the pituitary are not that common because it has all that accessory portal blood supply. That's infarct of the pituitary. You can still see the outline of it, but it's coagulative necrosis. It's very simple. It's not a brilliant diagnosis. You just have to remember that coagulative necrosis is the most common reaction to infarct, whether in the heart, whether in the kidney.
That would be like in a birth.
Well, don't forget, when we talked about Sheehan syndrome, didn't we say it was hemorrhagic? This is not hemorrhagic, but it is infarcted. So I would be very careful if I want to call this Sheehan syndrome, because you remember what the buzzword is for Sheehan syndrome? Hemorrhagic. But necrosis also. Okay, you know what? I think we're done. We did two major things. We've been here for over an hour. How about if we take our 10-minute break, and then we'll come back and do parathyroid and thyroid. And once again, I don't know, a lot of you have your laptops here. Maybe a lot of you are online. In every case, we talk about an entity. We're going to talk about a lot more entities. Even if I don't mention it, I want you to go back and Google the classical clinical presentation. If anybody knows of a website that will give you the classical clinical presentation for all of the specific disease entities that are in Robbins, that's the website you want to be at, okay? Well, we'll do 3 break songs. See you in about 10 minutes, and we'll have some more fun.
wanna do. I wanna love you, wanna hug you, wanna squeeze you too. But let me take it in my arms, let me feel you with my tongue, chaka. Cause you know that I'm the one that keep you warm, chaka. I make it more than just a physical dream. I wanna rock you, shock you, baby, make you wanna scream. Let me rock you, rock you.
We're back. We've had our 10 minutes of fun. Now we're doomed to one more hour of fun. Gee, life is really rough. Always, when I take the 10-minute break, I get one thought on my way to the bathroom. And I got a really nice thought. Like, do you remember, like, the last time we had a review session, we were actually serenading the buzzards? So guess what? We did a service to them, didn't we? Now, in a way, they're really doing a service to us, because when we're looking at things in laboratory and some questions are brought up, I know you're all looking at the screen there because I could see you. So they're helping you. And some of those people are a little bit higher up than medical students. Some of them are pathologists or residents. So this is a really, really good, I would like to call it a hybridization, but it's more like a symbiotic relationship. We're helping each other. So, you know, we will give them a service again on Thursday because we've picked out a nice song that we're going to sing by Shakira. And Carolina's going to be dancing for us. Okay, at least she'll be singing. And I'll probably wind up writing some kind of... Oh, how about if both of you dance then? Right? Believe me, I cannot dance like Shakira. If I tried, it would be really ugly, okay? But I think I'm going to wind up writing some kind of paper or making some type of presentation. And it's going to be something to the effect, at first I was just happy with being synchronized. But we're more than synchronized now. We're hybridized, okay? Here's the title of the paper in the Journal of Pathology, The Successful Genetic Hybridization Between Iguanas and Buzzards. So let's go into the last couple of organs now under the microscope. And we might as well start out with parathyroid because that's a smaller one, and then we'll do a lot of thyroid. But before we do, there's one other extremely important announcement that somebody has discovered. You see, when you have a bunch of people in a room, there's always somebody that's smarter than I am. So would you please share your knowledge with us?
Yeah, there's a site called USMLE Step 1 wiki.com that gives you like the clinical presentations of many diseases and many USMLE Step 1 stuff. So.
Okay, I knew there had to be something like it, but you're satisfied with it. So once again, if you take Robbins, USMLE Step 1 Wiki, find it, Google it, and from what I'm told, it may help you do what I think is very, very important. You know, not just for our school exams, but for all of you buzzards out there that want to take the USMLE as well. Well, no, I'm not going to go into that rant. Let's go into our microscope again. Whoops, wrong one. Where is it? Endocrine, lab slides. Now we're down to parathyroid. Okay, here's the best one. Parathyroid. Very, very, very simple. Easy to recognize. I actually took a snap of this one and I put it somewhere during our PowerPoint presentation. Is everything okay, Mario? And it's the best classical thing. You don't have to look at any more normals. You just have to remember what's the normal size. Maybe a piece of rice. You know, just like the pineal was also described as a piece of rice, or the parathyroids. It's at least 50% fat. You could tell that right away. So if the normal weight is something like, what, did I say 20 to 30 milligrams? You know, 1/10, 1/20th of a gram. Half of that is fat anyway. And then there's two kinds of cells. And it's easy to find the chief cells, which are the principal cells, which are the chief cells making the parathyroid hormone. And then there's going to be some oxyphil cells. Personally, I can't remember if the oxyphils make much parathyroid hormone. I think they make some, but if somebody out there is smart and they want to say for sure, do oxyphils make parathyroid hormone? I would appreciate it, because I'm kind of thinking mostly the chief cells do. So here's a parathyroid gland. As you can see, approximately what percentage of the cross-sectional area is fat? That's the first question. Somebody says 50. I personally might have said something like 57.3, but 50 is close enough. And I'm going to go into the cells now. And I can see a bunch of cells here. And so I'll zoom up this area. And I'm going to ask you a question. Somebody have the mouse, by the way. What percentage of the cells in this field are chief cells? Chief cells. Anybody want to guess? What are the buzzards saying? 90? High. Okay, that means that whoever has the mouse is under obligation to find the oxyphil cells. Oxyphil cells are always redder and bigger. So yeah, there's a few over there, and there's a few over there. Sometimes they're in like little clusters. They're not homogeneously mixed in. So that's your world's most normal parathyroid gland. Okay, increased amounts of those cells, you know, beyond the normal weight, beyond the normal size, result in hyperparathyroidism, usually. If it is a hyperplastic process, secondary to perhaps renal disease, probably both types of cells, chief cells and oxyphils, will be increased. If it is a true neoplasm, and also if it's hyperplastic, do you think it's more likely to involve all four glands? Yeah. If it's a true neoplasm of cells, do you think it's more likely to involve maybe just one gland? Yeah, but you know, but still a good number of the true adenomas are multiple. Not a lot. I think it's like 30% or something. It's more than a couple percent. Okay. That's all I want to say. I don't think there's anything more we can say. There's a little bit of a capsule here. I think I could convince you that maybe that's a little fibrous tissue. Or if we want, we could move around a little more just so we could say we've done our job. I'm going to point out about 30 oxyphil cells here. Everything from here to here to here out to here is an oxyphil cell. There's about 30 of them. And then all of these are chief cells. All of these are chief cells. By the way, did somebody find the answer to the question yet? Do oxyphil cells make parathyroid hormone as well? Anybody know the answer? Yes or no? I mean, not yes or no answer, but okay, nobody knows. That's okay. I don't either. Unknown? That sounds like a good thing that books say, unknown. That's the safest answer. Okay, but there's something else I wanted to say. Oh yeah, these chief cells that are making parathyroid hormone. What is the primary cell that they're going to have their effect on in bone? Osteoblasts, osteocytes, or osteoclasts? Osteoblast puts calcium into the bone. When you have a parathyroid hormone, you're losing it from the bone to the, so it's the osteoclast. So when I show you a picture of bone that has an increased number of osteoclasts, which are multinucleated histiocytes chewing up bone and spitting the calcium back into the blood. Yeah, it's confusing.
But I just saw an explanation that they said that the interrelationship is with the osteoblast, and osteoblast is the one who pushes the osteoclast. But
Okay, yes, there is a homeostasis. But the general rule is osteoblasts put the calcium into the bone, osteoclasts take them out. And that's the primary balance of the parathyroid hormone calcitonin homeostatic axis. the primary driving force of which is nothing more than the serum calcium level. Okay. Let's go to the next parathyroid slide. This is a good one. Isn't that interesting? Does everybody recognize this, by the way? It's bone. I think you all know that. There's the spicules. There's fat, 100% fat between the spicules. I might even suggest that these spicules look a little thinner than normal, but if you haven't seen a million bones, you don't have to agree with me. But look, not only are these spicules thinner than normal, but looks like something here is kind of like chewing them up even more. And here, and here, and here. Now, if this was 100% fatty marrow, then what marrow is this over here? This is hematopoietic marrow, isn't it? Because half of these cells are blood cell precursors and half are fat, whereas all the cells here are purely fat. What is this on the edge, all the way in the northwest, those things that look like cartilage cells? That's the articular cartilage, isn't it? Okay, so let's go to the part of this bone that looks like it's being dissolved. Like there. That's a good one. Now, you may not have seen a lot of bone in histology, but if you did, like the kids I was teaching at Chicago Medical School, they had a hard time finding osteoclasts in bone. They know that they're there. They know that there's a delicate homeostatic balance between osteoclasts and osteoblasts, calcium going in and out. But it wasn't always easy to find the multinucleated histiocytes, which are called osteoclasts. Is there any trouble finding them here? Hell no. There's a lot of them. And I'm going to point out in these areas osteoclasts, which normally are kind of hard to find. There's an osteoclast, multinucleated. There's an osteoclast. 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 It seems like every other cell here is an osteoclast. Now, can I ask you another question? What are these sort of individual cells that are rimming the spicule? Those are the osteoblasts, aren't they? And once the osteoblasts have actually surrounded themselves 100% by bone, they then get a name change operation. They are then called osteocytes. So what's the difference between the osteoblast and the osteocyte? The osteoblast lives at the edge of the spicule. Osteocyte is in the middle of the spicule. And osteoclast is always at the edge of the spicule, chewing it up. I'm going to find you another one. Maybe we'll have to go down a little bit first. Oh, yeah, they're all over the place. Okay, here's another spicule here and here. That look like it's generally being replaced by looser fibrous tissue, like the calcium is thinning out. Maybe it's going into the blood. So this is a process in which the homeostatic balance is shifting from calcium in the bone to calcium in the blood, because you have an osteoclast here, and 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 here. They're all chewing up the bone. When this is really prominent, very often they call these brown tumors. I know we didn't mention brown tumors. It's not in the test, but it's brown simply because bone is normally not that vascular, but when you have this process going on, there's a lot of blood vessels, so it looks brown. And plus the bone could be thickened as well overall, even though the spicules. So the bone of brown tumors is softer than normal bone. I don't know why I said that, but we're done with our looking at hyperparathyroidism as the main effect on bone. Now, let's look at another let's look at another parathyroid. Okay, I love this one because it looks like there's a nodule here, okay? It looks kind of red, but You know, if you think it's green, that's okay with me. Now let's take a look at the edge of this nodule. Like here, for example. Oh, look at that. It almost looks like a perfectly normal parathyroid. Most of these cells are chief cells, but look at, here's a couple oxyphils, here's a couple oxyphils, maybe even there's a couple more out here. But what about that big, big, big nodule? That's the majority of this parathyroid. What is that 100%? Chief cells or oxyphil cells? Do they look like perfectly normal oxyphil cells, except it's 90% and it's a specifically a thickening? So this parathyroid no longer weighs like 1/20th of a gram. It might weigh 5 or 6 grams. So what do you want to call it? It looks benign because it looks exactly like the normal oxyphils. It looks like it's an individual tumor because it's surrounded by a mixture of cells on both sides. And it's 100% oxyphils. So wait, I'm sure the buzzards got the answer. And probably when I look at my computer now, it's going to all say oxyphil adenomas. Okay, yeah. Oh, you can say adenoma. Oh, somebody said hyperplasia. I want to take exception to that. If a parathyroid is hyperplastic, you'll probably see a mixture of both kinds of cells. Don't forget, from the point of view of a pathologist, all they see is a parathyroid the size of a marble rather than a piece of rice. And they're asked sometimes, is this hyperplasia or is this adenoma? Well, if it's 100% of a certain type of cell, it's more likely to be an adenoma, isn't it? And by the way, I know what you're thinking. You're thinking, well, could there possibly be a parathyroid carcinoma? Yeah, there could be, but I've just never seen one and I've never heard of one. Maybe you could Google one, but if there was such a thing as a parathyroid carcinoma, do you think that patient would be hypercalcemic? It probably would not be functional, because if it's not looking like normal parathyroid chief or oxyphil, so it's probably not behaving like it. Last question. Come here. They have not heard you give me a kiss yet on the webinar. Okay, we officially started the day. What type of adenoma is more likely to produce hypercalcemia? Chief cells or oxyphils? Yeah, because remember somebody said that the oxyphil cells, their function is unknown, but they don't really make too much parathyroid hormone. Did you confirm that? So would an if two patients here had a parathyroid adenoma, one has a chief cell adenoma, one has an oxyphilic adenoma, which one is more likely to be hyperthyroid? The chief cell adenoma, right? Okay. This is a great case. And also, once again, you know, we've said it before, we'll say it again, we'll give you a lot of examples, but like all endocrine tumors, like all endocrine tissue, look at how vascular this tissue is. Look, you never have more than 2 cells before you got a little blood vessel. Look at all these capillaries. And in addition, do you also agree that in this oxyphilic adenoma, there's some atypical looking cells as well? Just give me the answer. Do they make it or not?
No.
Okay, good. Thank you. I trust that you can read very well, Carolina. Next case, another parathyroid. Oh, I don't know. Let's not get too fancy about this. Let's just say you have, this is 100% enlarged parathyroid. Now, primary hyperparathyroidism would be due to either hyperplasia or adenoma, right? Especially if they were totally independent of normal controls. But what if you have renal disease? And you remember in renal disease, as generally the potassium goes up the calcium kind of goes down. Well, what happens as a normal physiologic response when the calcium goes down? The parathyroids kick in. So even though it's hypocalcemia from the renal point of view, the normal reaction is to tell those parathyroids to start activating more of those osteoclasts. So that would be considered a secondary. Now this one was called tertiary, and let's just not deal with that right now. Let's just say it's not primary. Okay, so you have a situation where the parathyroid is enlarged, and you're looking at cells here. We're not looking at them high power yet. But here's the main question. Is this one type of cell, or is it at least two? Okay, why don't you drive around the big oxyphil air. Oh, you don't have it? Did you give it back to me? Maybe I have it. Okay. Let's see if she can drive around the oxyphil area, and then we'll blow it up and see if she's right. All you got to do is go to the areas that look redder. Like, for example, take a look at that area in the northeast. Do you think those are all chief cells or oxyphil cells? In the extreme northeast? No, all the way extreme. There. Are those chief cells or oxyphil cells? Okay, now take a look at those red cells, just a little bit deeper to that. Are those probably oxyphils? That's my guess, but, you know, that's why we have a microscope, is to keep us honest. So let's blow that northwest area up. Yeah, those are mostly oxyphils, don't you think so? So both kinds of cells are increased. That would tell you this is probably not a neoplasm, which would be primarily clonal, you know, either chief or oxyphil. It's probably hyperplastic, secondary or tertiary reactive process. And let me ask you this. If this was a secondary or tertiary reactive process, do you think that only 1 out of the 4 parathyroid glands would look like this? Or do you think they all would? Yeah, this is the general rule. So you know what I'm going to do now, Carolina, is I'm going to blow this area on my own, and I'm going to see if you were right. And if you were, I'm going to give you an A. Yep, you're right. Here's oxyphils. Here's chief. Here's chief. Well, maybe there's a couple of oxyphils down here. Let's go to that area that looks like it was almost entirely oxyphils. Like here. These are oxyphils, aren't they? These are probably mostly chief cells in here. Look at the intimate mixture. Here's oxyphils again. So you know this is probably not a true neoplasm. But nevertheless, I want you to go back again. I know maybe you could take a quick look. We're looking at pictures. Go back to the patient. Say, how did this parathyroid walk into the office? What did they say? What did they feel? And I already know the answer. How are most parathyroid adenomas picked up? Because the patients have symptoms of hyperparathyroidism or hypercalcemia, all those things we talked about, calcifications here and there, EKG changes. Practically speaking, most parathyroid adenomas are picked up because the patient goes to a lab fair or they're in the hospital and they get a routine chemical profile and they go, oh, look at that calcium is really high. So maybe they do a parathyroid scan. You could do it with ultrasound. You could do it with isotopes. And 100% curable if it's a primary adenoma, especially if it's not multiple. But if it's secondary to a renal process, chances are this guy had got more problems with his kidneys than he has with his bones or his parathyroid glands. Okay. Yeah. I don't like quick questions. Make it a long question. And I'm going to run up there and see if the buzzards can benefit from your quick question, too. Don't be afraid.
I'm actually kind of scared.
I can tell you're nervous.
Okay.
Okay, I understand in primary hyperparathyroidism, the reason they have hypercalcemia is because you have like something in the parathyroid that's producing excess hormone, right?
Yeah.
Okay. Now in secondary parathyroidism, patients present with hypocalcemia. Is the hypocalcemia due to an elevation in phosphate levels which lowers free calcium? Is it
Yeah.
due to an inability for the kidney to make calcitriol to absorb it in the gut?
Yes.
Or is it in the renal tubules?
Yes. But it's of renal origin.
Okay.
Okay, it has nothing to do with the parathyroid. Now, all these normal physiologic mechanisms, they come into play.
Hmm.
Maybe both of them do.
So it's more a reaction to
Yes,
the
it's a total
hypocalcemia.
reaction.
Okay.
Okay, and you just reminded me of something. Thank you. You think you did well? I'll give you another question now. Let's say a patient you suspect a patient has hypercalcemia because his calcium is high. It's not suspected, you can see it. But everything that you do, you examine his kidneys, examine his parathyroid, it's normal. But his serum parathyroid hormone is elevated. What's the most likely cause? Nope. Ectopic. When we talked about cancer, we went into the paraneoplastic syndromes, and many tumors, especially lung tumors, various kinds of lung tumors, not just the small cell, but the non-small cell, they can make a parathyroid hormone-like compound. It may not be exactly the same perfectly as parathyroid hormone. It may be a couple of amino acids off, but it still functions like parathyroid hormone. So when a person has hyperparathyroidism and his level is elevated, but there's no signs that it's coming from the parathyroid, think he has lung cancer. Or other cancers, but let's say lung, it's lung most of the time. Okay, are we done with this case? I believe we are. I think we have one more parathyroid case before we hit the big one, thyroid. Uh-oh, I got problems here. Do you remember, Mario, when we couldn't get the thing to move before? They can hear us, but I can't close this down. We got the same problem that we did before. Oh, here we go. We got it to do something now, I think. Uh-oh, I'm worried. We can't close this. And I don't want to have to reboot and start the webinar, so I'll try the simple thing first. Applications. Oh, shit. It's just not. Live Pick Deluxe. Let's see if that'll do it. I'm not happy with this. I'm not happy. Oh, shit. Well, folks, the same thing happened now that had before. We got a Puerto Rican computer freeze. So we know how to fix it. We know it's going to take 5 minutes of another break. We know that we have a good number more thyroid slides to look at. So I'm tempted to instruct both the iguanas and the buzzards that we're going to have to reboot the computer, restart the webinar, and do this. It'll take 5 minutes because, Mario, I can't think of any other thing to do. I don't know what causes that. Maybe we stressed the computer out too much today. Maybe if we kick it, we've kicked it several times, it just doesn't work. So, by the way, buzzards, is it clear we're going to be restarting the webinar in about 5 or 10 minutes? Do you understand that? Do you all know how to get back on? Okay, we'll be restarting. Sorry about that. But there's nothing else I could think of doing. Start task. We'll just try to, here we go, we'll say end task and see if that does anything. I don't think it will. Oh, wait, we got it done. But this thing still won't move too well. Hold on, we'll try again. We're going to go into thyroid now, if we can. No, we can't. It's a big delay. Okay, clinical skills at 10. Okay, look it. Folks, I know you got clinical skills at 10. We know everybody's been working hard. We don't want to make this more than 2 hours. So here, there's your normal thyroid. It's a slam dunk recognition. There's nothing else in the body that looks like thyroid with all these normal follicles, various sizes, thyroglobulin, follicular cells, making thyroid hormone, interfollicular cells here, making thyrocalcitonin. So, oh shit, this thing won't close either. Yeah, somebody's going to come in here at 10 o'clock. Okay. Well, you know what we're going to do then? We're going to have to use our brains. We're going to say exit, but this, by the time we reboot, it'll be time to leave. So here's what we're going to do. I'm going to go back to my little list over here and do a 5-minute summary rather than show you 30 minutes of thyroid. Okay, hello, discard, discard. This is very, very slow, but we won't have to reboot. And at least we say we've gone a couple hours. We did everything except thyroid, which of course is the biggest thing. Okay, let's see if we could close this too. Exit. Okay, good. Now, can we close that? Let's go to the bucket. And I'm going to just show you all of these, the rest of these thyroid cases. Okay, just give me 5 minutes of attention. We're not going to be looking at too many pictures. But you can see down on the list here, starting out, is thyroid normal. We've already seen that. Now, there's also a picture called thyroid, parathyroid normal. You can see, you know, parathyroid at the edge of thyroid tissue, looking classically, mostly chief cells. I want you to remember that even though your textbooks should always tell you that the parathyroids are right posterior in the thyroid and they're symmetrical, it never is like that. Sometimes they're intrathyroid. Sometimes they look like a parathyroid lymph node. There's a lot of variability to it. And like the adrenals, it's never where the textbook says they are. And all the surgeons will tell you that too. And then the one underneath that is called thyroid follicular carcinoma and thyroid follicular adenoma. That's going to be really easy because if I show you the picture of the thyroid follicular carcinoma and the thyroid follicular adenoma, the only difference that there's going to be is that you'll see the carcinoma growing through the capsule. The cells themselves look the same. It's pretty scary, isn't it? You can have perfectly normal looking thyroid, only it's gotten from the bone or the liver. Now, underneath that, there's a slide called Graves. And do you remember we said that Graves was also an autoimmune disease, except the antibodies activate the TSH receptors? So you're not going to see anything there except thyroid, in which really most of the colloid is depleted because of the hyperplastic situation. And if you look, there's an explanation to this, but it's best just to remember is that when you look at those smaller than normal follicles, a lot of them are going to have little vacuoles between the colloid and the follicular cell, almost like it's trying to pull away as an artifact. So that's what they call scalloping. That's the buzzword, okay? It's not just my buzzword. I think it's used everywhere. Now, the case after that is called Hashi. In fact, we have two Hashis. We're going to make this as simple as possible. If you cut through a thyroid that is Hashimoto's thyroiditis, it'll look probably like a lymph node. At least half the cells are going to look like lymph node with follicles, germinal centers. Now, if I show you one Hashi 1 and it's 30% follicles, and I show you another one called Hashi 2 up there, that's 80% follicles. Which patient do you think is going to be more clinically hypothyroid? The one where there's more infiltrates. And also remember, it is the most common cause in adults of acquired hypothyroidism. Hashimoto's thyroiditis, autoimmune thyroiditis. So Hashimoto's is to the thyroid as what Addison's is to the adrenal. Exactly the same. Next case below that was a normal one. And then we have a papillary cancer and a nodular goiter. Now, I would almost feel guilty showing you the nodular goiter because remember, you can't diagnose goiter under a microscope because the definition of goiter is enlarged thyroid. So how do you know from looking at a few cells whether the whole gland was enlarged? But nevertheless, very often it's nodular. So rather than those diffuse follicles like we saw in the normal, they'll look like they're a little more nodular. But you can't call it goiter unless you know that the entire weight of the gland was increased. So in adults, that would mean probably above 25 grams approximately. Now, I got two papillary cancers, and there were two things I wanted you to see. One is incredibly easy, and those are just papillary fingers, like you saw in so many other places. And also, some of those papillae dry up, and they become calcified, and they look like little whorled, calcified bodies, like you saw in other papillary carcinomas. Those are called psammoma bodies. You should have a visual instant recognition. They look so diagnostic. Now, the other thing I wanted to show you that we can't, because we're running out of time and the computer froze, is something I labeled there is Orphan Annie, because they're only or primarily in papillary cancers. And when you look at the nuclei of the cells that are lining the papillae, they don't look like they have any nucleochromatin in them. They look like they're white. They look like Orphan Annie's eyes with no pupil. So I want you to remember, maybe you could Google it right now. We've already seen it in the lecture, the Orphan Annie cell in papillary carcinoma, the psammoma bodies, which are dried up papillae, anywhere, not just in the thyroid. Any papillary cancer that dries up, we'll see psammoma bodies. But the main thing I want you to remember is that for all practical purposes, any true finger-like papillary structures that you see in the thyroid, you can comfortably call cancer. Okay, we'll call this a day. We'll play our closing song. I'm sorry I couldn't show you all these pictures, but we did give you a couple of minutes anyway to rest before your clinical something. And we'll see you on 48 hours, or actually 46 hours, for your review. I don't care if you're an iguana or a buzzard, but please, please, please study carefully the sheet of the important points that Jennifer has sent to you, all of you, right? See you in a couple days, folks.
When it's love you give, I'll be your man of good faith. And in love you live, I'll make a stand, I won't break. I'll be the rock you can lean on. Be there when you rise, to have and to hold. When there's love inside, I swear I'll always be strong. And there's a reason why I'll prove to you we belong. I'll be the world that protects you from the wind and the rain, from the hurt and the pain. Yeah, let's make it all fun, all for love. But the one you hold be the one you want, the one you need. 'Cause when it's all fun, it's one for love. When there's someone that you love, just let your feelings show and make it all fun.
Rock on, you buzzards. And I can't type anything into the chat box now, but I can tell you that I agree with Brian Adams, Sting, and Rod Stewart that whatever you do in your life, do it all for love. See you in a couple days.